Thank you, Ms. Alkire, for providing us with that troubling testimony. And I also would like to thank Mr. Johnson for bringing what I think is important, an important bill forward. I'm now going to recognize the members of the committee for questioning. And I'm going to start with myself. And Ms. Egorin, since I have been chairman of this subcommittee, this has been one of the primary issues that has been brought to my attention. And we've had several hearings involving the IHS, and we've brought folks from around the country. And this is something that is, I'll use the word again, terribly troubling. We made some commitments to these folks, and it is time that we meet those commitments and that we fix this system. One of the ways to do that, I think, is to address the fact that we understand that there are some IHS area offices that have significant PRC carryover funds. In other words, they're holding the cash instead of spending it and doing what they're supposed to be doing with it. So, with some regions having carryover in the tens of millions of dollars, I obviously find that terribly unacceptable. How much of this carryover is due to PRC purchase orders that have not been reconciled or otherwise closed out by the IHS? And does the IHS have an action plan to address this backlog of open purchase orders so that the individual tribal members are not contacted by providers to pay these bills?
Congresswoman, thank you very much for that question and actually for your commitment to bringing this forward. This is something that is shared by Director So, and it was reflected in PRC being one of the top 3 issues on her work plan for IHS, as well as clearing the OIG recommendations from the OIG report that highlighted the challenges. In terms of unobligated funds, one of the steps that she's taken is really setting a target of only 10% to making sure that dollars are flowing out. In terms of your specific question, I would like to be able to get back to you with that on the data of how much are unobligated funds from claims that have not been processed.
And I'd also like to have a timeline as to when that will be addressed, that these funds are actually spent on the people that are entitled to that money to make sure that this does not continue to happen. Another follow-up question is that the HR 7516 establishes a mechanism for PRC service reimbursements to be completed within 30 days by the IHS. And in your testimony, you mentioned that this timeline would be impractical, even though the IHS handbook requires the service to pay PRC claims on a 30-day timeline. What is the practical difference between 30 and 45 days?
Congressman, I think I actually want to start with a place of we should never have dollars going from tribal members out. Pay and chase is not a goal. So to be able to say, what can we do to stop even having that should be the place of emphasis, and there are parts of the bill that get to this. In terms of that 30-day reconciling, it is a matter of the staffing, which has been referencing, making sure that we are meeting our statutory obligations, but in constrained staffing and constrained budgetary times, giving us the ability to have a goal, but also to have the flexibility to make sure that we are following the law.
Well, what is the medical industry standard for reimbursement when a patient pays a medical bill that insurance should be reimbursing them for?
Congresswoman, there is not actually a standard, and it's part of the reason that Congress has passed several pieces of legislation to keep, I'm going to put this in quotes, patients out of the middle when there's a conflict between providers and insurers. Reminder that IHS is a direct care organization and not an insurer, so a lot of the mechanisms that are in place for billing do not exist within IHS for reimbursing patients directly.
So I know that this is an important issue to you. I know it is an important issue to you, but after 15 months of hearing about this from our tribal members, it's an incredibly important issue for this committee as well, and I really encourage the IHS to do everything that you can to fix this. I'm going to go to Mr. Frank White-Clay. In your statement, you provided details of situations where individual tribal members have been impacted by IHS not paying the PRC bills. I'd invite you to expand on your statement and ask if there are any further examples you'd like to provide to the committee, because I think it's extremely important that we document the problems and the challenges that your members are facing.
Thank you, Chair Hagerman. Yes, there's we'd be here all day if I got to all the issues that came out with IHS on PRC issues alone. we'd be here for another week if it was all the IHS issues compounded. But just in one instance that I gave out earlier on the young woman that was denied for her college loans, we have issues of a elderly gentleman, an elder of my tribe that's a veteran, actually paid out of pocket. He had hearing aids that through the PRC program, and he went to get them recalibrated through that, and actually was authorized through PRC, and the service provider denied him that care specifically because IHS hasn't paid that bill for that patient directly, and he had to pay out of pocket. And I asked him and when he was going to get his reimbursement, and he said, I don't know. It's been a few months now, and I don't think it's ever going to come.
Has it been resolved yet?
No.
Okay. We may follow up with additional written questions so that we can have other examples for all of you on the challenges and these problems. I now recognize the ranking member for 5 minutes of questioning.
Thank you very much for the testimony and for laying out what it looks like for individuals who should be receiving the care. And I do appreciate, Dr. Egorin, the idea that there should never be a need for reimbursement, right? But what this legislation does is sometimes that happens. And so we need to get it done quickly. But I'm wondering if, based on the testimony I've heard today, if we need to actually go a little bit further to provide that 30-day so that claims, when they do get paid for whatever reason, but also to make sure that there should never be any referral to a credit agency of monies that are due when you should be receiving referred care, so that it could not be used for your credit score. And quickly, I'm going to go on down the line and ask, Chairman, do you think that that would be useful?
Yes, it would be very useful. It should never have happened where the tribal member does receive the bills of collection. And in the case that it should never even happen if PRC was doing its jobs.
Yeah, and Chairman Erickson, I think some of the points you pointed out in your testimony actually dealt with the failure of when things got sent away. That always happens, right? When things get sent away, they would not process. So that was actually another big problem. But Chairman Erickson, would you also, how would you consider an amendment which would say you could not use these bills and these debts in credit rating, because they're not the debts of the individual, they're the debts of IHS? That's how I see this.
Yeah, that's accurate. And I would also state, I don't know if it's Congressman Johnson that mentioned, it's a joke, but those 32,000 unpaid PRC bills, I wonder if those are all call bills, because that's a joke, but it's not, because it's like we have 20 to 24 million roughly of that PRC money in the region that isn't being for our unpaid bills. And so it's incredible. And it's not our job to staff IHS, right? Currently, we're a direct service tribe, so we haven't contracted that service. That's their job to staff those, to make sure they have the staff to process those bills in time. 30 days seems like a sufficient amount of time to get those reimbursed for people. We have elders on fixed income. We have people going to college who are on fixed income. They don't have the means to even pay that bill, but they're doing that so their credit isn't impacted, so they can get their loans for whatever they may need to further education, to just pay their electric bill if they're an elder. So I think that's, if there's appropriations issue there, that's their job to make sure that they go and talk to you all to get appropriations required to fully staff and fund their programs. That's not our job. As of tomorrow, we have 0 primary care physicians at our IHS clinic. 0. We won't have any staff at our local Nispian clinic. So there's a bigger issue here too with that, but I just wanted to. But yes, to your question, I'm sorry.
That's a bigger issue. Ms. Alkira, you're also Alkari. Ms. Alkari. I wanted to. Both you and Dr. Egorin both mentioned in your testimony that there is a need to make sure that bad actors that that we address bad actors, right? That the providers who violate these provisions, some of it is educating them, but then there was another part that there are no consequences. Could you sort of speak to that real quickly? Because I also want to get feedback from Dr. Egorin on it as well.
I think when I talk about that, I meant that there's no penalties for the providers when they send those bills to the tribal members. So even the folks in talking to our CEO on this issue in regards to the PRC and her saying that it's all about education with the providers, because as Chairman said, we're direct service tribes and most of us have clinics. We don't have hospitals. So all these higher levels of care go away from the tribe and they get sent out. So we're really relying on folks like the big hospitals like Sanford and Avera and all these other ones. And every time they, at those big ones, there's all these levels of care for our people. You can have orthopedics, neurology, and then they have to be educated about the purchase order and the PRC. And then that's where the confusion lies as far as we get the bills back to the tribes or back to IHS. And they don't realize that that's really hurting our people. They just send the bills back to our people sometimes, not because they're not educated in regards to the
part
IHS
of it.
system.
So my time has gone up, so I won't be able to has expired. So I won't be able to hear the response of Dr. Egorin. But part of it,
go ahead.
Yeah, sorry. But part of it is an issue of education. But another part of it that both of you touched on was an issue of consequences. And I would love to have you submit written response to that, Doctor, so that we can understand a little bit more what you would be looking for in terms of suggestions. Because I think it's great to hear suggestions when we have a legislative hearing so we can improve the legislation before us. So thank you very much. And with that, I yield back.
Thank you. The chair now recognizes Mr. Lamalfa.
Thank you, Madam Chair. For Assistant Secretary Egorin, following up on that previous thought right here, with basically the HHS program being just flat ignored, it seems. What examples is there of other forms of disincentive or basically consequences when the rules aren't followed in other areas of the HHS, other programs that we can look to as examples of beefing up enforcement in this particular area?
Thank you very much for that question. And I'm going to give a short answer, recognizing time, and then offer for you or any other member of the committee, I'm happy to bring our subject matter experts across HHS.
I'll toss it to Ms. Alkire right after you. Thank you.
Yeah, but I was going to say, and you can look to examples like civil monetary penalties or conditions of participation that are used in CMS, and there are some places we can leverage that, but there are examples of how to hold providers accountable for following statute and for giving teeth behind what their obligations already are. So as I said, we are happy to provide technical assistance and briefings on what is done. I want to make sure I give you the full spectrum because, as you know, HHS has Medicaid, Medicare, our HRSA programs, our SAMHSA programs, and partnerships with other direct care providers.
Is there any actual consequences, any punishments?
So, for example, civil monetary penalties are a dollar amount that providers have to pay. And the best example that people know about is sort of HIPAA violations. Covered entities have an obligation for when your information goes out, how much per day they have to do. There are similar obligations for balanced billing provisions. I don't have the specifics of the Medicaid program in front of me, but I know there are consequences there as well, and I'm happy to provide that in writing.
So if that amount of teeth that apply to those programs were shifted, could be applied here, do you think that would be strong enough?
I think that what I've heard from my IHS colleagues is the lack of teeth, the lack of enforcement is definitely a challenge. For PRC, it is not the only solution, but it stops that bill going out.
Okay. Ms. Alkire, what you want to touch on that? Mr. Erickson seems to have. I saw him shaking his head. I said, I saw Ms. Alkire's going to have first shot at it, and I'll come to Erickson. Basically, as we've seen in other HHS programs, there is consequences that when they aren't getting the job done, and other forms of punishment, we'll call it, that if they were applied to this area here for the PRC and for the people involved in that, would that be something you would suggest, or do you think would be effective in that from your experience?
Yes, I think it would be very effective if we had some type of penalties for this, because I think when you talk about most of our people, a lot of them are on Medicaid that go up to these, that's their insurance. They do Medicaid, then they go IHS. But a lot of our people, when you have providers, the only penalty that comes for folks that are providers is that it comes to their license, and
No fines or no
yes,
no real punishment. Okay, so we're hearing a trend here. Okay, Chairman Erickson, it's your turn at the plate.
I just wanted to elaborate on that. So a lot of us tribes that are here are very rural tribes, right? So we have our services we get referred out to are usually 2 hours away each direction. I know Chairman Whiteclay's, they may be 4 hours. So I'm not opposed to if there's a repeat offenders, some sort of penalty, what that might be, but it's IHS's job to educate these providers because they may deny services to us that we may not get anywhere if we start penalizing them too much. I think we got to be cautious about how that looks and what we need to do. Maybe for the repeat offenders, there's something like she mentioned, but I just want to make sure we're cautious about that because some of us have limited amount of providers that we have. So if they're penalized, they may not want to work with IHS or
thank you.
Tribes at all. So.
All right, thank you. Chairman Whiteclay.
Yes, thank you. I want to reiterate that because of what we've seen right now, and the biggest city near us is Billings, Montana, is an hour away from us. But we have seen with our elderly patients that are going there is that they've been denied service because of PRC payments being late, and then for an elderly cataract client, now they're going from 1 hour away to 5 hours away into Ms. Alkery's state of South Dakota to Rapid City, 5.5 hours. They're referred out to there with and the travel, the rooms, etc. is all on the elderly tribal member. So like we said, we'd like to be cautious on some of the penalties and everything else that goes out with that because of our limited number of providers to our tribal members. So it's a catch-22 for us also.
So don't scare them off then, really, so too much. So, but doesn't this kind of bum out your members from even trying at all when they get to that point? Yes or no, or fast yes or no?
Yes.
Yeah, okay, thank you. Thank you, I appreciate it. Thank you, Madam Chair.
Thank you. And the chair now recognizes Ms. Peltola for 5 minutes of questioning.
Thank you, Madam Chair. It feels kind of out of place having a totally different conversation now about my bill, but and I do want to say this bill that has been discussed and 4 of you are here to testify on, this is important, and this is important to Alaska Natives as well. We are also Indian Health Service beneficiaries, and I think it's worth noting that if you look at the services and the quality of care that Indian Health Service provides, under the circumstances they provide them in terms of being underfunded so chronically year after year after year, if agencies across the board were as underfunded as Bureau of Indian Affairs and Indian Health Service, I think we could show that we actually are overperforming for the amount of resources provided to these agencies. So I just kind of want to stick up for Indian Health Service a little bit here because I know that you're short funded every year. But in regard to the Alaska bill regarding ANCSA and providing relief to disabled people and blind and elders for their trust settlement, Sherry, I was wondering if you could share and tell us a little bit about how settlement trust benefits are created and distributed and how they follow the broader intentions of ANCSA.
Thank you. Thank you for the question. I I fought hard to get our settlement trusts in a place where they could benefit our shareholders in a meaningful way, to have non-taxable distributions. And so many of our programs for our elders, 62 to 65, and then 65 and older, are extremely beneficial to them. And so I just wanted to speak to that we've done a demographic, and historically, Alaska Natives, American Indians, Native Hawaiians, their rate of their life expectancy is lower. So, getting these benefits to them while they're still alive is extremely important. And so we use these settlement trusts as a vehicle and a mechanism to be able to benefit their tax position and maximize their benefit that they're receiving for the limited amount of goods and services they're able to buy with them.
Mr. Chairman, if I could follow up.
Yeah, go ahead.
Thank you. Could you elaborate on some of these difficult choices that your shareholders face, and maybe give some examples?
Yes, thank you. I had several elders call and say that their Social Security benefits had been adjusted when they had received settlement trust distributions that were calculated, and so they're on fixed incomes, and when their Social Security benefits are adjusted months out after a distribution, it really affects their ability to count on being able to buy groceries or get their family to them. There's a lot that really use these for glasses and dentures, like I said, and just basic human needs that they depend upon.
And most blind people or disabled or very elderly, they don't have an option to have like a side hustle. They're not. They don't have other options to help subsidize things when they're off track with their benefits.
Yes, that's right. They're, especially in these remote villages, that they're small populations, and so their families end up caring for them beyond what they can afford to care for.
How many people would you guess this will affect?
For Chugach, we estimate we have, of our 2,900, 700 are over 65, but not all of them are in that the poverty level that the threshold affects. But it's about 24% of our population.
Okay, thank you. Thanks, Mr. Chairman.
Representative Peltola, thank you very much for your questions. I just leaned and spoke to the ranking member. I said, "You're asking all my questions, and they're very good." I will now recognize myself for 5 minutes. I appreciate being waved on to this committee and to talk about a very important piece of legislation, including H.R. 2687, which I am very proud to co-sponsor with my good friend and colleague from Alaska, Representative Peltola. Ms. Beretta, these might seem same or similar because they are, but in your role within the Chugach Alaska Corporation, you certainly see this issue affecting the Alaska Native elders and disabled natives who are from the Chugach region. Is this issue equally affecting other Alaskans from different parts of Alaska?
Yes, definitely throughout the state.
It's throughout the state. And how many did you say from the Chugach region?
Approximately 700, which is 24% of our total.
And so my understanding of the Alaska Native Settlement Trust is they're meant to help provide much-needed income to Alaska Natives. Wouldn't it be counter to the purpose of these trusts if Alaska Native elders had to turn down or return the benefits out of fear of losing federal housing and nutritional assistance?
Yes, and it's devastating to them to have to think about either turning their shares in or trying to figure something out so that their other benefits are not affected.
It would be devastating for the families, right?
Yes.
Individuals and the families. I know you and other Alaska Native leaders have been working on this issue and different forms of this legislation for quite some time now. Can you expand upon that from your perspective, including your work with the late Representative Don Young?
Yes, Congressman Young cared deeply about our people, our elders especially, and I know that this was a very important piece of legislation for him. They are our precious elders. They carry our wisdom, and for us to not honor them by protecting them in every way we can is irresponsible.
You know, I look at this situation. This Representative Peltola, this seems like so beyond reasonable that this should have been done a long time ago. I am happy to, co-lead this with you. It's very similar to those Americans that have public pensions that also qualify for Social Security. They don't get their full Social Security. It's called a windfall exemption, and it just doesn't seem to be right. They should not have a reduction in their benefits that they've earned for fear of losing their housing or nutritional assistance. And again, Representative Peltola, thanks for leading this Congress, and I'm just thrilled to get this over the finish line out of the House, and we'll get it to the Senate and hopefully pass it into law. To all the witnesses here, thank you for your time and your expertise and your leadership. It's greatly appreciated, and I will yield. And then Ms. Schreier, you are up for 5 minutes.
Well, thank you, Mr. Chairman, and thank you, Madam Ranking Member. Thank you to all of our witnesses today, and really thank you to members of this subcommittee for allowing me to participate in today's hearing to speak about the Purchased and Referred Care Improvement Act. I am so proud to lead this bill with my colleague from South Dakota, Congressman Johnson. Over the years, leaders of the Colville tribe have shared stories with me about the hardships that tribal members have faced to obtain health care from the Indian Health Service. And this particular bill addresses what I've come to learn is an all too common occurrence at the federally managed IHS service units, where tribal members find themselves referred to collection agencies because IHS did not pay the healthcare provider. So let me be super clear about how this goes. Primary doctor in the IHS refers a patient for care from a specialist or another provider not available in the IHS system. So they go outside of the IHS community for community care at their provider's recommendation. And then rather than IHS paying, as they should in a timely manner, the patient ends up getting stuck with the bill. And then if they can't pay, it goes to collections, and then it can affect their credit rating. This is a really big deal. The Colville tribe's story is particularly unfortunate because it appears that these issues worsened when the IHS Portland area assumed direct management of the PRC program. And I understand that the tribe is working to contract all IHS programs to ensure that tribal employees carry out these important programs. Chairman Erickson, it is so nice to see you again, and thank you for taking the time to meet with me earlier in the year and recently, and for being here today and raising this issue so that I could join forces with Representative Johnson to address it. Your written testimony discusses how some providers who have taken referrals from the IHS program are considering abandoning the PRC program altogether because they're not getting paid. And then they can't stay afloat. I was wondering if you could elaborate on this and maybe discuss any other impacts that the purchase and referred care issues you describe in your testimony have had specifically on the Colville tribe and the surrounding communities.
Yeah, thank you for that question. So there's really two directions our members can go: west to Wenatchee or east to Spokane to get these specialty services. If those aren't available, the next closest is more than likely Seattle or Portland, which is 4 hours, and then 6 hours to Portland, 4 hours to Seattle. So it's similar to Chairman Whiteclay, that's not really feasible, right? And then if the members aren't covering that on their own, out of their pocket, then the tribe helps with some emergency services they have. But then again, it's still IHS's obligation to pay those bills, and then the tribe is either paying money to help those elders or people that have specialty care needs, or that member themselves is covering it. Some impacts that have happened from this is people just don't seek the care anymore. So they let things linger and they become bigger issues that don't get addressed. We've had a lot of people, even in my family, had cancer, stuff gets not addressed, and then they end up getting worse and stuff happens. I've had my own instances where I've had to pay bills myself, had bills of collection. I'm on council and I have the means to, but it's like I'm trying to hold the IHS to their federal trust responsibility, and they still don't end up paying those bills. And so I end up covering some of those myself, which I shouldn't have to either, especially not our members on fixed income, our elders, and low-income individuals.
Thank you for painting that picture. And of course, the tribe's resources are not unlimited either. So I'm sorry that you have gone through that and that so many of your members have gone through that. And I hope that this bill remedies the situation. So thank you again for informing me, and thank you for being here today. And I'm eager to get this over the finish line. Yield back.
Thank you very much. I want to thank the witnesses for their valuable testimony and the members for their questions. The members of the committee may have some additional questions for the witnesses, and we will ask you to respond to these in writing. Under Committee Rule 3, members of the committee must submit questions to the committee clerk by 5 p.m. on Friday, May 3rd, 2024. The hearing record will be held open for 10 business days for these purposes. If there is no further business, without objection, the committee stands adjourned.